Abby and our team, I think, probably started working with UVM and Dr. Niles and her team shortly after the pandemic started, and a lot of work was done around food insecurity, and we had some early surveys of needs and so forth. So that has evolved over the last couple of years, and we have more research that's been out for maybe a couple of months that UVM has done, and they've updated some of that. So I'm going to turn it over to Dr. Niles. She can introduce her team about the program and what they can share with us. And then towards the end, we'll have an opportunity to ask questions and more information from there. So Dr. Niles, it's all you, and you can introduce your team and we'll go from there.
Thank you very much, Secretary Tibbetts. It's a delight to be here. For those of you I haven't met yet, I'm Meredith Niles. I'm an associate professor in nutrition and food sciences at the University of Vermont. It's a pleasure to see so many people here today. We're delighted to see the interest in the state government for our work, and we thank you for your support. We have a brief presentation this morning. Hopefully I can share my screen here. I did want to first briefly introduce my colleagues that will also be presenting this morning. So Farrell, would you like to introduce yourself, and then Jennifer?
Yeah, thrilled to be here. I'm Dr. Farrell Bertman. I'm a senior lecturer and a registered dietitian nutritionist. I'm the director of our graduate coordinated dietetics program, and I see some of our MSD students on the call as well. I want to join my colleague in saying thank you so much for your support, and I'll turn it over to Jennifer.
Good morning, everyone. I'm Dr. Jennifer Laurent. I'm an associate professor of nursing. I'm also a practicing nurse practitioner, and my area of interest in terms of research, which has brought me to this team, is primarily obesity and how obesity intersects with all types of health outcomes. So, and thank you for having us.
Great, thank you. I'm going to go ahead and get started by sharing my screen here. Give me one moment. Get this all up and running. Okay. Hopefully everyone can see that. So I just wanted to briefly introduce the rest of our team, some of whom I think are joining us this morning, and give you a little bit of background about the broader suite of work that we've been doing. And then we're going to spend our time today really focusing on our most recent research around food insecurity and health outcomes during the pandemic. So I've already introduced myself. Yep.
Meredith, I just wanted to let you know we see your presenter view with notes.
Thank you.
You're welcome.
Is that better?
That's perfect.
Thank you. Thanks for that. All right, so I've already introduced myself. Also on the call with us today is Maddie Alpaw, a research assistant with our team. Dr. Bellarmino wasn't able to join us. We also have Sam Bliss on our team that's joining us this morning, a PhD student. Eric Clark, Ashley McCarthy, a postdoctorate working with us, and Scott Merrill rounds out our team. We've had a lot of support from students as well. And the work that we're doing is part of a national collaboration that UVM started called NFACT, the National Food Access and COVID Research Team. And so we are founders and leaders of this effort that began in the summer of 2020 to really collectively document the impact of the pandemic on food security and food systems across the country. So we have 18 study sites in 15 different states, which you can see in blue on this map. We also have done nationally representative samples, which are shown by the gray states in the map. And our website's there, nfactresearch.org, if you're interested in learning more about some of that work. Our NFACT research group, including this group, has really focused on three core principles. And that is, first, that we work with stakeholders from the beginning. As Secretary Tibbetts said, we partnered with state agencies from the beginning of our work to include them in survey design, to hear about their needs in terms of data collection and data measurement. We've also vowed to make our work open access to really ensure that people outside of a university, including many of you yourself that work in government, have access to our information. And our third principle, which relates to the work we're presenting today, is to make the work actionable by prioritizing public communication outputs and engagement with policymakers. So we put out policy briefs of our research. You can see some snapshots of ones here, more recent ones that we've put out in the last several months. We have 12 of those on our NFACT website that range from March of 2020 data all the way up to the most recent brief that we released last month. We also have several peer-reviewed publications that have resulted in this work, which are also accessible on our website. So before we jump into telling you a little bit more about the specific health outcomes research, I wanted to share a little bit about the multiple surveys that we've done so that you have a sense of other data that's available, and also to situate the work we're presenting today as compared to other work that we've done. So in total, we've conducted 6 surveys of Vermonters since the beginning of the pandemic. And you can see in this figure on the right here, I've color-coded them based on the kinds of surveys that they were. So we have cohort studies, and then we have representative studies. We've also conducted a farmer and food business survey in conjunction with the Agency of Agriculture in August and September of 2020. And so collectively, we have data from more than 6,700 Vermonter responses over this time period. We've also done qualitative interviews with key informants. Those are led on our current project by Sam Bliss, our PhD student we're working with. And so today, the data that we are presenting are from a statewide representative sample, representative on race, income, and ethnicity that we conducted last year in the spring and summer of 2021. We partnered with and have a project with the University of Maine for this current research. And so the data we're presenting today, sometimes you'll see Vermont data, sometimes you'll see Maine. If we don't indicate otherwise, it's pooled together. And it represents about 1,000 Vermonters and Mainers. And I did want to share, and we hope to have more conversation about ways to engage with state agencies and stakeholders more. We have a forthcoming USDA Rural Development Grant that's starting in March that would provide funding for 2 additional surveys in 2022 and 2023. And that's really focused on rural food access and health access during the pandemic. So I'm going to turn it over to my colleague Farrell now to share some key takeaways and dig into some of our most recent findings. Farrell?
Thank you, Meredith. I'm really pleased to be here. And so when we think about our key takeaways, we'd like to elevate a few considerations. About a quarter of Vermonters are food insecure. Since March 2020, half of our Vermont respondents indicated mental wellness concerns such as anxiety and/or depression. Food insecure respondents may be at higher risk for health impacts, including changes in their use of substances and medications over the last 2 years. Further, Vermonters reported changes in weight status during the pandemic and an anticipated need for investment in programs that promote health behaviors and psychosocial support may be needed within the next 3 to 5 years. Our findings also include health equity implications that are emerging and should be prioritized. Lastly, we anticipate that long-term health impacts connected to multiple shocks to well-being may require a multifaceted approach to access, investment, and expansion of existing programs. Next slide. Thank you. So let's look now at food insecurity further. Looking at our findings since March 2020, food security has improved, but food insecurity still remains higher than before the onset of COVID-19. The majority of food insecure Vermonters are working. Of our food insecure respondents, 71% are categorized as working, retired, or homemakers. We found that our respondents are concerned with food costs and inflation, and this probably comes as no surprise if you listened to the news at all recently. In 2020, we found that food insecure respondents are experiencing changes in their diet variety. Our current findings indicate that 1/3 of food insecure respondents are continuing to report consuming less fruit and vegetables. Next slide, please. As our team reviewed results across different demographic categories, we were struck by significant health and wellness patterns among Vermont lesbian, gay, bisexual, transgender, and queer respondents. We've partnered with the UVM PRISM Center for advice on properly sampling sexual orientation and gender identity, or SOGI demographics. and they're continuing to be our partners moving forward. Our sample of LGBTQ+ Vermonters suggests significantly higher rates of food insecurity, mental wellness concerns, and hypertension. Now I would like to hand the microphone over to our colleague to continue our discussion. Jennifer?
Good morning, everyone. I'm just going to take some time and kind of go through some of the more pertinent things that we found in terms of chronic health outcome. And as an obesity researcher, this slide really hit home to me in terms of what we're seeing in obesity and overweight rates currently. And again, this is just a snapshot and we're not drawing any causality, but according to what we're finding is that individuals in Maine, but also in Vermont, are much more likely to be overweight and obese as we had thought compared to some other statistics. And we do know that according to our findings that these individuals are all individuals, 43% of them are reporting weight gain. So when we look at predominance of obesity to a lesser so overweight individuals in Vermont, coupled with a weight gain, we can really see how the potential for increasing chronic disease onset, but also perpetuating chronic disease outcomes or poor outcomes might be of significant concern in the next 3 to 5 years. We also, and this, I don't think that this is anything new to anybody, especially if you're a clinician, is that our respondents that had type 2 diabetes and hypertension also reported a higher body mass index. Next slide. So we really dove into the major drivers regarding, sorry, I have to take my phone off the hook, major drivers related to chronic disease, and those are regarding hypertension and diabetes. So here we can see some of the national statistics, and then we have Maine and Vermont statistics. So I'd like to draw attention to the right side of the figure in terms of what our Vermont statistics are. Sorry, somebody clearly is trying to get a hold of me on my phone. I apologize, everyone. So when we look at the type 2 diabetes statistics for Vermont, compared to what our national statistics are is 3.7%. And we're finding that about 9.9% of individuals that responded to our survey are reporting diabetes. And then if we look at our depression in terms of our national statistics, we find that 51% of individuals in Vermont are reporting depression. And again, we're not really finding causality. We're really looking at correlation in terms of the incidence between COVID and some of these health statistics. Next slide, I believe. Again, I think something that was really surprising to us and certainly very concerning as a clinician is that we're finding that our food insecure respondents are really stopping and skipping medications related to their chronic disease. So here on the right, you can see individuals that are food secure and how often they're reporting either skipping or stopping their medication compared to those who are food insecure. And so we can see anywhere from 15 to 22% of people are skipping medication. And in terms of their diabetes, it looks like just as many who are skipping their medication are also stopping their medication. And what we're finding, what we will find is that this will make it even more difficult to provide primary care services, but also to kind of halt that chronic health disease burden that happens with uncontrolled hypertension, diabetes. And importantly, we know that there's a relationship between depression and anxiety and how people take care of themselves and how that relates to depression and diabetes type 2. Next slide. We looked at the incidence of substance use kind of at a little bit of a superficial level. And the reason I say that is that we combined a lot of the illicit drugs that are reported, such as oxycodone, heroin, methamphetamine into a category of street drugs. So you'll see that we just really looked at street drugs as an overarching term: tobacco, cannabis, and alcohol. But what we have found, and I don't believe that this is any surprise to any of us, is that individuals are reporting greater use, specifically in terms of alcohol and cannabis and tobacco. We're also finding that individuals are more likely, when they're using one substance, are more likely actually using a second substance. And again, I don't believe that this is any surprise, but we find that those that are food insecure are more likely to actually increase some of their substances, such as tobacco. We noted that individuals that were newly food insecure, so our survey asked if they or measured food security status within the previous 4 months of our survey. And those that were newly food insecure, so endorsed being food insecure within those 4 months, were twice as likely to actually increase their alcohol intake. And this just suggests that individuals are struggling, which I think we're all aware of, and maybe compensating with substances to deal with some of their mental health issues. Next slide. So I think I'm going to turn this over to Meredith to talk a little bit about this slide, and then I think I'll jump in afterwards, if that's all right with you, Meredith.
Sure, I'm happy to review this. So we've presented some of the data that we have found since the start of the pandemic, and now almost 2 years into the pandemic. We wanted to think about some of the implications for policy and moving forward, and then open up for discussion and talk about partnership and next steps. So these results really demonstrate that there is a need for continued support for food assistance programs, even as unemployment falls. And I've had a lot of conversations with media and others about the fact that our unemployment rates are so low right now, and yet we're still seeing high rates of food insecurity, as many people are struggling to keep up to earlier impacts on their economics. We also think that investment in healthcare access and promotion of preventative care is really important, especially with non-COVID etiologies and social determinants of health. And our results really suggest that we might think more carefully about layering support systems. So we're identifying that food insecure individuals and some populations are lacking access to food, but also potentially access to medicines, increasing substance use, and potentially lacking healthcare. And so thinking about co-location of resources could be really beneficial, as well as coupling benefits, so medication vouchers, for example, that accompany other programs to provide support. We've also identified some health disparities in this work. Our other research previous to this has also identified huge disparities in terms of food insecurity. For example, research we have under review right now for 3 time periods of results from Vermonters suggest that BIPOC individuals in Vermont are 10 times more likely to be food insecure in the first year of the pandemic. And of course, this work identified that LGBTQ+ respondents are uniquely vulnerable, and we should be thinking about health inequities during recovery from the pandemic. And we also think there's an opportunity for enhanced use of academic, state, and nonprofit partnerships. So obviously we're at the university, but there's a lot of potential for coupling different agencies and different institutions and working with students. And then I know Jennifer might say more about this, but also thinking about reinvestment of preventative efforts aimed at chronic disease and obesity, as we're seeing these potentially increase or have longer term impacts. Did you want to add anything there, Jennifer? Oh, you're still muted.
Darn. No, I think you covered it nicely. Thank you, Meredith.
Okay, great. So we just wanted to wrap up then to really hear from all of you. You're working at state agencies and other organizations, and we really want to think about how can we help and partner, and how can we think about working together to solve and provide data and information and support for these many challenges. So I did mention early on, and I'll repeat it, that we have a forthcoming grant focused on rural food insecurity and health outcomes and health access during and since the pandemic. We have an advisory committee for that, which currently the Agency of Agriculture is serving on, but we would welcome other participation from relevant agencies. We're interested to understand what are the major areas of need and interest for your agencies, what data needs do you have to inform decisions, and how can our work help? And then finally, what are we missing and what should we be thinking about further that maybe we haven't captured? And so before we open it up for questions, I did want to acknowledge our funders of this work, the Gund Institute for Environment at the University of Vermont, as well as the Northeast New England Center for Clinical Translational Research. And we're really happy to be here and look forward to the conversation and questions.
Thank you, Dr. Niles. I guess we could open it up for questions. You can raise your hand. There's a lot of people on the line, but if anyone wants to go first or et cetera, I'm curious about how we're going to get people back on taking their medicine again. I mean, that seemed pretty striking that people are, and it seems, and then I can believe that, but how do we achieve to get people back taking their medicine again? They should be on.
Is it okay if I go ahead and answer that, guys? So I think that what I probably didn't actually be mentioned when we asked them, we were asking them why they were skipping or stopping, or if they stopped or skipped their medication related to financial cost, meaning they couldn't afford their medication, so that they were either stretching it out, and we see that a lot. We're just happening to notice it more in our data at this point. So I think that medication vouchers actually would be really helpful for individuals. We found that actually Vermont did a better job than Maine, and I think that speaks a little bit to our Medicaid program and our ability to reach out to our individuals. That's just a kind of a guess based on, working and practicing. But I think that medication vouchers is probably a really great way. So these medications, a lot of them tend to be very inexpensive. So if we can somehow give them a 90-day, voucher to bring to a pharmacy, it might go far in helping them.
Thank you. Secretary Samuelson has a question.
Yeah, first and foremost, I want to thank you for the work on this. I think that it's really interesting data and offers an opportunity to really dig into it. My question is more of a statement. I'm hoping that you have a report and or can share the slides out of this so we can dig into it a little bit deeper and into the findings. And so would be excited to have you share that with our team so we can disseminate it among a couple of the departments to look at.
Yes, thank you, Secretary. I will put a link to our report in the chat so everyone will have it, and you can feel free to share that broadly.
Thank you.
Okay. Any other questions? How do we approach the weight gain part? I mean, we're all that doesn't surprise me. How do we write that one?
I can get us started from a dietetic standpoint. And what's wonderful about our team is we do have multiple approaches to weight gain. Within our work in dietetics, we're thinking very carefully about barriers to preventive care. If people are experiencing psychosocial changes due to weight change, then how do we address those barriers and make sure that there are inclusive mechanisms to bring people back to their primary care physicians, to the registered dietitian nutritionist, and then work with them in terms of what do these changes mean to you, and then how can we think about the sort of etiology of those changes, whether it is due to changes in mental wellness, food access, joyful movement, and how we can begin to create and amplify new pathways for health.
And I'll just add that in terms of, weight gain is really tricky, and obesity and overweight are very, very complicated issues, both, socio-environmentally, but also physiologically. So you know, we have had a community-based intervention, Rise Vermont, that has been successful, and there's a paper out there demonstrating reduction of weight in extremely obese elementary school children, and that stemmed from the community. And I think that UVM offers the perfect practice opportunity with the state and VDH to actually engage our students and our researchers and our you know, individuals that are involved in the community to really kind of support and enhance and sustain those community-based programs where the community identifies these are our needs and this is what we need to do to get healthy. So I'd love to see more investment, not just on the state, but investment, you know, statewide and all the resources into really looking at those community-based initiatives. Because we know that if we can control weight in the youth, we can help control weight in the adult population and families. So,
Abby Willard has a question.
Yeah, thanks, Anson. Every time I hear this data presented, I appreciate it. I keep thinking about the comment of just increasing fruit and vegetable consumption by Vermonters. And there's certainly a variety of programs that are addressing that need. They're probably woefully underfunded and need a lot more support. So we could think about the Vermonters Feeding Vermonters program. There's even a program that Salvation Farms is running, which is getting seconds into the Department of Corrections, which I think is a great program. The healthcare shares concept I was thinking about, because it's really about this health, kind of food as medicine concept of treatment through access to free or subsidized CSA shares. And then, you know, there's a new opportunity through U.S. Department of Agriculture called the Local Food Purchase Assistance Grant Program, where the Agency of Agriculture will have access to not a lot of money, so only $500,000, but about getting locally produced foods from socially disadvantaged farmers to socially disadvantaged populations. And so it's really the exact objective of, I think, what this research demonstrates is needed. So anyway, those are from the agricultural and food production side, the things that I keep thinking. And then Commissioner Levine, I just think about our health and all policies conversations that we've kind of stalled for a bit because of the burden of the pandemic. But that effort is so much about bringing together all these different conversations with health as the overarching objective. So no question, I guess, but just any ideas on the new partnerships or the coupling of resources that we might be able to do with some of those program ideas.
Yeah, absolutely. Thank you, Abby, for all of those comments. You know, I think our data suggests that all of those are programs we should be promoting as we see especially the impact on food insecure Vermonters. And so especially thinking about those low income disadvantaged Vermonters as targets, I think is critical. So I think another space I know your agency is interested in, of course, is the school meals program and the role of local fruits and vegetables in the school meals program. We are starting to dig into our food consumption data a little bit further. Dr. Bellarmino, who's not with us today, is really focused on understanding dietary changes more since the pandemic, and we have a much larger suite of data that we've collected. And so one thing we might look at moving forward, for example, is how participation in federal or state programs relates to dietary changes or dietary consumption, for example. So I anticipate that in the future we may be a little bit more clear on saying how certain programs may have outcomes based on different participation rates, for example, on diet. I will just mention, and Dr. Bertman might want to elaborate on this, we did find, for example, in last year, Dr. Bertman led a publication focused on food banks, and we did find that food insecure households that utilized food banks in the first year of the pandemic were less likely to reduce their fruit and vegetable consumption. They were more able to maintain it. I don't know if you want to elaborate on that, Dr. Bertman.
I would only say that it is open access, so I dropped a link to our paper in the chat, so feel free to look through that and follow up with us if you have any questions. And Abby, I completely agree that as we have a multifaceted approach, and as I like to think about in global nutrition, a twin track approach, where we're investing in infrastructure at the same time that we're making sure that our charitable food system is robust. That's where we're seeing at least a mitigation of these barriers and reductions in fruit and vegetable intake. Dr. Levine, I'll hand the mic over to you.
Thank you. Just to echo some of the comments, I know that during the pandemic, there were great efforts made to maintain the lunch portion of school, even when maintaining school was not possible. And I wonder, though your data set doesn't give us insight, are you aware of other data sets that give us insight into what's happened to weight gain and some of these emotional factors during the pandemic to the school children? We talk about them all the time in very dire ways, but at the same time, it'd be helpful to know if the adult experience is paralleled by the younger children experience with regard to obesity, since when things begin at those early ages, we know that there's the extra burden on trying to reverse them more quickly. We also believe that that's a more resilient population, but we know that even pre-pandemic, the incidence of obesity and type 2 diabetes in adolescents and younger was getting astounding. And so I can only surmise that it probably got more astounding during the pandemic. But I think in a brighter sense, we try to use the word resilience a lot and regard that age range as more resilient and perhaps able to reverse some of that. So I'd just like to hear some of your comments regarding those thoughts.
I can take a
Probably could all weigh in there.
Go ahead.
Go ahead, Paula, you start.
I would just say, I think another, I don't have an answer for you that's coming out of our research, but I can also suggest a growing body of evidence that's looking at the psychosocial impacts of weight gain in the pandemic. Our colleague, Dr. Lizzie Pope, is looking at very alarming increases in eating disorders and disordered eating since COVID. And so as we're looking at these programs, just continuing to think about how changes in oneself, one's identity, and potentially size could lead to additional psychosocial issues. And so in particular, she's looking at how social media is coupling with COVID during this time and negatively impacting adolescents. And I'll hand it over to Jennifer.
Sure. To answer your question about large data sets, University of Vermont is a site for the Adolescent Brain Cognitive Development Study. That's this 21 consortium site throughout the United States. And they have genetic measures, neurological measures, lots of psychometric testing that's all really very sound, and socioeconomic data. And what they've done is they've actually started to inquire about the relationship of COVID. You know, how has COVID affected your life? I think there's probably a 15-question panel that has been incorporated in that data set, and it's about 14,000 kids. And I think that they've assessed 12-year-olds, 13-year-olds, and 14-year-olds. So that data is coming. How well we can dial it in to Vermont per se, as opposed to the nation, is a remaining question. We do have some geographical coding within it, but just to mean that de-identified kind of human subjects piece, we may not be able to drill down really distinctly into Vermont. However, a colleague of mine and myself are actually investigating that data set. So the release is, I think, about to be set through the NIH, and again, we'll be able to look at that a little bit more closely.
I just wanted to add as well, as we think about the school lunch program, you're correct, Commissioner Levine, that we do not work with children in our current work. We do have data on household composition. So we are able to, for example, understand, and we have looked at this previously, how households with children are affected during the pandemic. And unfortunately, we have found historically in our other surveys that households with children are significantly more likely to be food insecure since the pandemic. And so we know that there is a direct impact on children, or at least on adults in households with children. I would add that we do have data around participation in the school meals program that we've captured at multiple time points. And I just have to say how overwhelmingly positive that data is. I think it's really hard sometimes to think about the pandemic and to really understand the full weight and impact of many issues here. But we also have some bright spots in our data that tell us that we really implemented policies and took advantage of federal vouchers and other areas that made a difference. And so overwhelmingly, the data we have around the school meals program, as well as the expansion of SNAP and WIC and changes to those policies, suggest they were incredibly helpful and that they were very important for continuing to ensure food access for children during the pandemic. So I don't want to underscore the importance of those policies, and we have found very clearly that they have made a difference.
And is there a way in your data set to parse out worsening of known conditions like diabetes, obesity, hypertension versus the actual onset of those conditions as part of the burden of the pandemic?
I'll briefly say something and I'll turn it over to Jennifer as well. And this is useful feedback for us as well as we're thinking about our next survey and designing that right now. The way we asked the question previously in our data that we're reporting today was asking people about whether they had a condition and whether they had the condition before COVID or since COVID. We're also exploring opportunities now to understand and tie that self-reported data to maybe some more stringent numbers like A1C that would give us some sense of severity of a potential chronic disease. But Dr. Laurent, do you want to add to that?
Meredith, I think you covered it nicely. I don't actually have the statistic of anticipated new onset. We also really phrased the question not related to a clinician diagnosis, but like have you since the pandemic been told you have high blood pressure? So that doesn't necessarily mean it's a clinician diagnosis, because we all know that you can have your blood pressure taken different ways, and you can borrow somebody's glucometer and have your blood sugar taken, without going to see any type of provider. So I think as we move forward, that's something that we're really looking into, to look at new diagnoses. And I can certainly email you, and it may or may not be in our brief, I can't recall, the new onset or the reported new onset according to respondents.
I would like to add as well, one of the things that we're considering moving forward, we've had some chat about this. I just wanted to make sure everyone was aware for our next survey that we're designing right now, and we're hoping to share with the different agencies for feedback, is also thinking about healthcare access. So better understanding what kinds of insurance people have, how frequently they go to the doctor and seek medical care, and really looking at the relationship of health access to some of these outcomes that we're seeing as well. So we hope to dig into that further with our next round of data collection coming up shortly.
There's a question in the chat about lactation, food security, especially thinking of the shortage of infant formula. I don't know if there's any data or information on that.
Yeah, I'm happy to step in here. For those of you who have access to the chat, I dropped a practice paper into the chat. As part of the NFACT team and broader collaboration, I had an opportunity to work with some folks nationally that are dietitians looking at how COVID is impacting infant formula use. It is a practice paper directed for registered dietitian nutritionists, but I hope is accessible to all healthcare workers. We didn't at the time have direct numbers on the shortage, but it does provide a social ecological model in terms of how, as a healthcare team, you can work with people who might be at risk for food insecurity or other drivers to use homemade infant formula, and how we can kind of help steer people either towards breastfeeding, relactation, or the use of commercial infant formula. I would be more than happy to send this. I believe this PDF is behind a paywall, but I was lead author and happy to privately send it to anybody who would like to look at it and doesn't have access.
Thank you. How is telemedicine everything? Do we have any indication that, you know, as people are not in person visiting their doctor or their primary care or whatever, how is telemedicine? Is it any indication how that's played out here?
You know, and I don't think we really looked at telemedicine. I mean, certainly telemedicine has become its own, you know, huge part of providing primary care services. And in terms of creativity and using telemedicine or telehealth services to, you know, assist with non-office visit related issues, you know, maybe in terms of accessing nurses or dietitians or physical therapists or whatever. I'm not really sure where that's at. There also is that the reality of the billing of the practices, right? In terms of like having providers or nurses that are providing these services but are not billing for these services, and that's kind of that messed up world we live in terms of insurance. However, that does offer some unique opportunities for us to actually investigate using telehealth services to provide some of these things for individuals who can't really or are too far remote or don't have access to services that might be offered in more urbanized areas. So that would be a great opportunity for the state or VDH to maybe partner with UVM and maybe even work with some of our doctoral students who are really looking at trying to, you know, come up with projects, basically, research or evidence-based to really help the needs of Vermonters.
And I'll just add that, I have some of my MSD students on this call, and they're gaining right now with your partnerships with the Vermont Department of Health, with WIC, the University of Vermont Medical Center, incredible skills on telehealth. And although sometimes we would love to have more on the ground clinical opportunities, I think that this is such a fantastic way to build competencies in telehealth. And thank you so much to our preceptors for leading the way in this area. And I can say that the Academy of Nutrition and Dietetics is considering competencies within telehealth moving forward, even beyond humanitarian events that might keep us apart.
Secretary Tebbetts, I would add as well that as we focus on this new grant, this USDA Rural Development Grant, telemedicine and telework as well is something that we're investigating as potential influences on transportation and access to food and healthcare. So we will be asking about telemedicine and telework in our future surveys, so we can come back to you as we learn more about the relationship of those to different health outcomes and food access issues.
Any other questions? Check out the chat. There's a lot of information populated. But we want to, if there are no other questions, we really want to thank you for your partnership, your research. It'll be valuable for all the different agencies and departments as we move forward, and we hope we can continue the conversation. And we'll look for next steps. And we want to thank our partners at the Department of Health for joining us today, and also Human Services being on the call today. A lot of great people doing some amazing things as we enter the next stage of the post-pandemic, whatever we want to call it, right, Dr. Levine? I don't know what we want to call it, whatever the next stage is. But we appreciate all of your help, and we'll continue to engage with you.
Well, thank you so much for the invitation. Our team is really grateful to have the opportunity to connect with so many people on the ground, and I hope we can reach out and get your feedback on our forthcoming survey and really make sure that we're asking questions that are relevant for the needs of all of you as you think about your decisions moving forward and what data can be helpful. So I've put my email in the chat. Feel free to reach out to me or to others on our team, and we're always happy to connect and learn more about the needs that are in the community.
Thank you so much. Everyone have a great Friday. Ready?
Thank you.
Bye-bye. Bye-bye.